Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. This is coming out on October 9th, 2025, and we're going to talk about maintenance therapy for small cell lung cancer. Now, maintenance therapy is very well known and established in non-small cell lung cancer. That was last week's episode, talking about the pivotal data behind maintenance pemetrexed. But we're going to talk about maintenance therapy for small cell lung cancer, and this is in the setting of the IMforte study, which led to the recent approval of lurbinectedin maintenance in combination with atezolizumab. So IMforte is a study of patients getting their 4 cycles of platinum-based chemo, platinum etoposide with atezolizumab, and that's followed by continuation maintenance atezolizumab. We know that from the Empower 133 study. We also have the Caspian study, similar design except swap out atezo for a different PD-L1 inhibiting monoclonal antibody in durvalumab. Okay, what this study is asking is, all right, so after these folks get through their 4 cycles of platinum-based chemo, they don't have progression, they're randomized either to lurbinectedin plus atezo or just atezolizumab. Now, we'll come back to, let's do it now. Let's just do it now. For both of these studies, Empower 133, which is the atezo study in extensive stage small cell lung cancer, and Caspian, which is their durvalumab equivalent study, the median OS in the atezo study was 12.3 months compared to 10.3 in those who got placebo. Caspian, it's 12.9 versus 10.4. Very similar median OS in both our control group and our experimental group or at the time the experimental group getting the immune checkpoint inhibitor. 36-month or 3-year overall survival is looking 17.6% respectively between Caspian and Empower 1-3. So that's just kind of a baseline of what we're seeing, okay? So IMforte, they actually, I think it's notable that they screened, like 900 people. 660 get enrolled into the induction phase. Of those 660, 483 move on to the second phase where they actually are enrolled, and that's where they're randomized to atezo plus lurbinectedin or just atezolizumab. And that I think underlines that this is a pretty sick patient population. This disease state moves very quickly. In fact, many of these patients, we see them in the hospital, and sometimes you have to start treatment in the hospital because by the time you wait, if you do outpatient, waiting for them to get central access and to get set up and to do the chemo education, they're too frail and they die before you start treatment. You got to start treatment pretty quickly. There is a window that closes. This is a pretty fast-moving disease. And so for a fast-moving disease, you would expect the primary endpoint to be overall survival, but no, it's split between progression-free survival and overall survival. I do want to point out that unless there was a contraindication per protocol, all these patients on lurbinectedin receive prophylactic G-CSF, and that makes it into the label. Also in the label, you give your immune checkpoint inhibitor first. You give atezolizumab, then lurbinectedin, for those of you building these EPIC protocols or whatever your EHR is. And the label also says for both single agent lurbinectedin, but then this combination with atezo in this maintenance indication is you do your 5-HT3 antagonist and 8 milligrams of dex as an antiemetic. Notable because of the immune checkpoint inhibitor component. At least for cycle 1, they say to do that, and then kind of best make your case there afterwards. 80% of the people in this study, this is a study of about 480 people, 80% of the people in this study, Europe or Middle East, I think mostly that is Turkey. About 15% receive prophylactic cranial irradiation. Somewhat controversial in the extensive stage setting, but that is notable. And those are well balanced between both arms. About 90% had a response to treatment, either complete or partial response. Again, very fast-moving disease, very aggressive disease, very highly active or very highly proliferating disease. Therefore, very susceptible to chemotherapy, at least initially. Okay, so I won't bore you with the PFS data. It's positive, favoring lurbinectedin atezo versus just atezo, again, in maintenance. But the overall survival endpoint here, we do see a median OS of 13.2 with lurbinectedin plus atezo compared to 10.6 months with atezo. Now, this is not from the beginning of chemo. This is from randomization to either lurbi, atezo, or just atezolizumab. And our 12-month overall survival is 56.3% compared to 44.1%. That's at 1 year, 12% more people are alive. That's a number need to treat of 8. That's quite a robust improvement in overall survival here that we're seeing. We don't have long enough follow up yet to see kind of benchmark how much are we improving long-term survival with this, but pretty clearly we are improving overall survival compared to just continuing your immune checkpoint inhibitor. Now, when you look at that overall survival, you do have to ask yourself the question, what are the people getting when they progress on atezolizumab? And the rates of, subsequent treatment with lurbinectedin are pretty small. Only 22 of 240 people on the atezo arm got subsequent lurbinectedin. About 13% got topotecan, some were retreated with platinum. The numbers of retreatment are pretty small, which is probably reasonable for this patient population because they can progress so quickly that they may not be well enough to receive that second line treatment. Other notable things to point out here in IMforte, there's nothing to really take out of our subgroup analyses. Everything looks pretty much the same. There were twice as many grade 5 events on the lurbinectedin arm, 12 total versus 6 total with atezolizumab. There was more immune checkpoint inhibitor toxicity, so serious adverse events of interest for atezo, 31% on the lurbinectedin arm versus 23% on atezo. I don't think this is the combination is more toxic. I think they're probably on atezo longer because they're living longer and they're going longer without progression. And so they're doing better. And to that end, more patients received corticosteroids on the lurbinectedin atezo arm than just atezo. And again, we're seeing still a positive benefit in both PFS and overall survival here. So this is, I think, a modest, it's not huge, but it is and it's not small, but it's a modest improvement in overall survival in a really challenging to treat patient population. I think pretty quickly will be established as or adopted as standard of care and make it into the guidelines pretty quickly. Now, the next maintenance thing is too early for prime time, but is exciting. This is Delphi 303, and this is a non-randomized phase 1 study. Now you're thinking, John, non-randomized, phase 1b, what can we possibly take from this non-randomized study? Well, maybe not a lot, at least based on the evidence-based medicine purist standpoint. However, this is adding tarlatamab to either atezolizumab or durvalumab as first-line maintenance. So again, right after you get your 4 cycles of platinum-based chemotherapy, these patients were then put on study to either continue atezo or durvalumab plus tarlatamab with the 1 milligram initial dose, then 10 milligrams every 2 weeks. It's a small study. It's only 88 patients. And again, there's no comparison to anything else. It's kind of like playing a basketball game by yourself. You're always going to look good without a defense there, okay, without a comparison. It is, again, 88 patients. Median follow-up was 18 months. So again, have not been on study very long, but the median overall survival, before I even say this number, remember, median OS for platinum plus immune checkpoint inhibitor with continuation maintenance of atezo or durvalumab is not more than 13 months. We just saw in the lurbinectedin and atezo maintenance study, median OS was again about, what did I say it was? It was like 10 months again. It was like 11 months, right? 12 months. Let me go back to that. Median OS was 13 months. It was 13 months. Now that's from randomization to maintenance. So then let's add on, you got 4 cycles of chemo. Maybe that's 15 months total, okay? Or 16 months, okay? That's pretty good, right? It's still pretty good. What we're seeing here is a median OS of 25 months, which is the longest described in any, extended stage small cell lung cancer study we've seen. 25 months median OS, okay? The other thing that I think is really interesting and is promising is that we are seeing a plateau in a progression-free survival curve. So if you look at the percent of people alive without death or progression of disease, at 9 months, it's about 35%. At 12 months, it's about 35%. At 15 months, it's about 35%. And so these are folks that have not progressed that you're wondering, are they getting some long-term benefit from this longer than we expect? We don't see that plateau in our progression-free survival with lurbinectedin maintenance with atezo. Both those PFS curves still kind of, the limit goes to 0. They both kind of meet at less than 20% by 18 months. We're not seeing that long-term plateau. Now, we don't know that there's a long-term plateau yet with tarlatamab plus immune checkpoint inhibitor, because it's only 88 people, for crying out loud, and we've only followed them for a year and a half on average. But it is pretty promising. And as far as, is this actionable? I wouldn't suggest you start putting people on tarlatamab and immune checkpoint inhibitors. There are some that may, certainly. But if you've got a patient who wants the next best thing, I would certainly, help them find access to clinical trials, because there are clinical trials out there for tarlatamab in limited stage, but also in extensive stage of disease. There's Delphi 305, which is recruiting at a ton of sites, and you can go to clinicaltrials.gov in the US and find those sites all over the country, internationally. It may not be accurate because it's a .gov site right now in the US, but hey, that's the best that we got. So that's what I have this week. Maintenance therapy for small cell lung cancer is entering prime time, it seems, and maybe these treatments will grow, and the treatment options will grow over time. There's going to be, there's currently in study a subcutaneous tarlatamab as well, and maybe that's coming down the pipeline. That makes its use in the maintenance phase a little bit easier and more attractive to community sites as well. So lots of exciting stuff coming here in maintenance for small cell lung cancer. Thank you so much for listening. You can follow me on X at PharmDeaton, follow the podcast at UnclePharmPod at various social media platforms. And until I talk to you again, remember, doses matter.